بسم الله الرحمن الرحيم. السلام عليكم لكل المستمعين. Welcome to all audience. I know we have the audience outside the Arab world, so welcome you all. This is our first neurology club for the year 2020-2001. I'm talking from Alexandria, Egypt. This is the neuropsychiatry department in Alexandria University. We used to have a neurology club every month, and with the era of Corona, the good side of the pandemic of Corona, that we started to use the internet and communicate on the web, and we use this advantage to invite to our neurology club international speakers, well known. I don't have even to introduce them. Their name is known by itself. We choose a topic that is very important clinical to all of us, especially who works in the neuromuscular field. We all face refractory cases. I do have many cases of myasthenia gravis that make hard time to me to get to remissions. I have patients who have dermatomyositis and endomyositis, and they have hard time to get to remissions. We have patients in the peripheral neuropathy groups, the acquired type. We have still difficulty to treat them, some patients. So we choose this difficult patient or difficult group of patients to invite our speakers to share with us their experience with such difficult cases. Dr. Howard, James Howard, I will start to introduce him. All of us know Dr. Howard very well. Dr. Howard is the former James Howard Distinguished Professor of Neuromuscular Disease and Chief of the Neuromuscular Disorder Section at University of North Carolina, Chapel Hill in the USA. He is a practicing neurologist for over 41 years with a focus on myasthenia gravis and DMG. I am one of his students. He is a lead and has authored more than 70 abstracts, 150 articles, 30 book chapters in the field. He currently directs the myasthenia gravis clinical trials and translational research unit at UNC. Dr. Howard was the 2019 recipient of the European Academy of Neurology Investigator Award, and is frequently invited to lecture on myasthenia gravis at national and international meetings. He is a member of the NIH funded Rare Disease Clinical Research Network for Myasthenia Gravis, MGNet. Dr. Howard has served as the lead principal investigator for the Alexion ocrelizumab phase 2 REGAIN trial, open label extension, and champion MG studies, the Rare Pharma Zero Plan phase 2 and studies, and the Arginex Efgartigimod phase 2 and 3 studies. I am sure that have a very good lecture with Dr. Howard, and I'm sure that all of you enjoy his talk. We will have a discussion at the 3 talks, so keep with us to have a chance to talk to him and ask him about his experience in myasthenia gravis. I worked with Dr. Howard like 25 years ago, and I show pictures for him on bikes promoting for myasthenia gravis with his colleague in Duke. He did a great efforts in myasthenia. Yeah, I saw that. He started the plasmapheresis manually. He did a great job in myasthenia gravis. He loved it. He adored myasthenia gravis. Now, and finally, I will let the stage for Dr. Howard to start his talk to us. Please, Dr. Howard.
Salma, thank you very much for that kind and warm welcome. And it's been 25 years since we've seen each other, and
yes.
Unfortunately, with COVID, it has to be virtually. Alexandria is on my bucket list because I want to see the great library,
Yes.
a very natural wonder of the world. So today we're going to talk about refractory myasthenia. And refractory is probably a bad term because even our worst of patients, we can help a little bit. We just can't control their disease. So probably uncontrolled myasthenia may be a better term. But when we look at the history of the word, it dates back into the early 90s and has been carried forward and has been used operationally in some of our clinical trials. And what I hope to do today is to set the stage of where we are currently in treating these kinds of patients and where we've come over the last 12, 15 years with new therapeutic strategies. And I think the hope looks good. We can help our patients who have been devastated by this disease. These are my requisite disclosures. I consult and receive research support from many of the pharmaceutical companies that are dealing with this issue, with Alexion primarily and Raw Pharma, which is now part of UC Bioscience. And I'm going to show you some of the data from our clinical trials, but several of the others as well. In the US, there were no FDA-approved drugs for myasthenia gravis until October 2017. The cholinesterase inhibitors were grandfathered in by our Food and Drug Administration back in the 50s. And in 2017, eculizumab came, and we'll talk about that. Everything else that we use, and we'll talk a little bit about them, are used off-label in the United States and have become standard of care, if you will. And we won't go into depth in those. I'm not sure what the health ministry in Egypt has approved for use in MG, but probably similar in part to what we have here in the States. So what is refractory? There is no consensus. Administrative units have used the clinical trial definition of regain, which said you had to fail at least one or more immune therapies for more than a year, or one therapy and then be chronically treated with plasma exchange or IVIG. That's really not a great term. I have a patient that I see here who is a computer engineer for one of the IT groups here in Research Triangle Park, who has just double vision. But the double vision is so bad that he can't work more than an hour on a computer screen without developing profound headaches. And he must take a period of time for rest and regroup from that. And so clearly it's impacted his quality of life. And to me, if we're to use the term refractory, he's as refractory as anyone else. He's been tried on multiple therapies, plasma exchange, etc. The literature suggests that about 20% of the patients we see do not respond adequately to our current therapies. I suspect if we take into quality of life or the adverse event profiles of the drugs we use, that number may even be higher. And so the goal that we are trying to achieve is targeted therapies with very narrow adverse event profiles that improve strength in the overall well-being of our patients. And we're getting closer, and that's what I want to show you today. So I like to start with a case report. This is not my patient. It was a patient of Vern Jules just down the road at Duke University that we published back in 2017. Disease onset in 25 with subacute bulbar weakness, rapid progression over weeks to involve ocular and limb and respiratory domains. He had antibodies to the acetylcholine receptor. He had a decremental response to repetitive nerve stimulation in his trapezius muscle. And following his thymectomy, which was performed 8 months after disease onset, he had a single myasthenic crisis and ended up in the hospital on a ventilator for a period of time. What you see here is the list of therapies that he's received, the kind of improvement or response that he had in sort of the age range. And so he was treated for virtually his entire disease course with cholinesterase inhibitors. And while they were beneficial, they were only partially so and transient. If he stopped them, his improvement went away. He had very limited improvement with a nearly 20-year therapy program with high-dose prednisone that was subsequently tapered. Thymectomy did nothing for him at age 26. He would receive plasma exchange or plasmapheresis periodically, and he got markedly better, but it was very transient, lasting only a few weeks, and then he would relapse. IVIG was tried, didn't help him at all. Azathioprine was tried with no improvement, though I suspect his treatment duration or treatment course may have been too short. He received cyclophilins, cyclosporin. He had some improvement, but very inadequate, and no improvement with 7 months of therapy with mycophenolate mofetil. And so this is one who we would say has uncontrolled disease or refractory, if you will. When we look at what happens to patients with MG over the course of their lifetime, one can see that patients improve here in orange, substantially so. We've improved that aspect. We've improved the death rates, which is here in this teal color, substantially. But patients who achieve remission in light green or who don't change here in blue are sort of our nemesis. And so we fixed sort of the outsides, but we really haven't helped the middle, if you will. And this is David Grobe's personal experience of nearly 1,000 patients, more than 1,000 patients, over a 40-year time period when he was alive in New York City. When we look at disease burden, and one of the ways we can measure that is looking at the activities of daily living score, and something 6 or higher, and higher is worse, represents substantial impact on their activities of life. More than half of the patients have disease burden that we would consider substantial. Similarly, quality of life indices show where lower is better, higher is worse. Many of our patients have a mean score of 22, which is substantial impact on their quality of life. Now, this is a point-in-time measurement, but without question, the effects of myasthenia on our patients are not without significance. Our treatments are fraught with lots of problems, and I've listed here cholinesterase inhibitors, steroids, other non-steroidals, immunoglobulin and plasma exchange, rituximab, etc. And one sees, and we're not going to go into detail in all of these, multiple side effects that produce unwarranted issues, whether it be mood changes, weight gain with steroids, glaucoma, diabetes, whether it be bone marrow suppression, hepatotoxic toxicity with some of our ISTs, plasma exchange with hypotension, sepsis because of indwelling catheters, etc. Rituximab is not without risk. And some of these, in fact, have long-term toxicity that we have to keep in mind in terms of osteoporosis and diabetes with steroids, and the hepatotoxicity that I mentioned, nephrotoxicity with IVIG, and the cyclophilins, and PML sometimes with rituximab. And the third issue that we face is that the therapies that we typically use take so long to work, on average many months, other than prednisone, which takes several weeks before we start to see beneficial effects. All of these are intolerable situations for our patients. They do it because they have no alternative, but they're clearly not happy about this. And the call to us, the call to arms, is that we have to do better. Just to review briefly, because this is probably known by all of you, that there are multiple mechanisms of synaptic blockade in myasthenia. We typically think that there is antibody blockade, so the binding of the antibody to the acetylcholine receptor complex prevents in one way or another the actual binding of neurotransmitter to the binding site of that receptor complex. It's usually because the IgG molecule of the antibody is so large that it sterically hinders the ability of transmitter to reach its target. Binding of antibody, cross-linking of these receptors accelerates a normal turnover process. Receptors typically undergo internalization, degradation, and new receptors brought to the surface every 7 to 10 days. An antibody accelerates that process. And so we end up with a net loss of receptors on the postjunctional membrane. And if enough are lost, then we start to impact on what we term the safety factor of synaptic transmission, and weakness will start to occur. So let's talk about what we use for refractory MG. Many of us here, at least in the States, use rituximab or have used rituximab. It remains controversial. We all agree that it's very effective in the MuSK form of MG. We're still at odds as to whether it's really beneficial in receptor-positive MG. And the rationale is to destroy and deplete pathogenic B cells and thereby decrease acetylcholine receptor antibody production. But it has an influence on the entire B cell spectrum, in antigen presentation, cytokine production, T cell stimulation, for instance. And at least here in the US, in Canada, North America, there are two regimens that we typically will consider. Many neurologists use this 375 milligrams per meter square body surface area weekly for 4 weeks, and we may repeat it in 6 months. The rheumatology colleagues and those who trained under rheumatologists here use 1,000 milligrams on day 1 and day 15, and then we watch and see how effective we are. The trouble we have is that the majority of the literature is a small case series with varying results and often without a control population. And here are two. One talks about high efficacy of rituximab in MG, comprehensive Austria study. The trouble is it's retrospective. There is no real control group in here. And while there was clinical improvement in many of the outcome measures that were used, it's called into question because of the small number of patients used and the retrospective nature. There's another study looking at new onset generalized and refractory MG, and one sees that rituximab clearly was beneficial when compared to conventional forms of therapy, but again, small numbers of patients and retrospective in analysis. There has been one blinded study, a randomized controlled study done through the NIH here in the US. Richard Nowak was the PI, and he showed that there was no difference in those patients treated with rituximab to those who did not receive it in the ability to reduce the prednisone dose. And so these curves followed fairly similarly. And when one looked at the MG composite score, one of our indices that we use, there was no appreciable change in this group. And so this is a failed study. There are some questions of whether there was proper study design. Were we fooled in that because prednisone is such a great drug, we were not able to pick up differences? The other big problem is that most of these patients only had mild disease. And I think that created an issue and the ability to see change. So we had a regression of the mean to the floor, if you will, and therefore we couldn't see any substantial signal. This has not been published yet. I've been told that it is coming out sometime in the future, but I'm not aware of the date that it is. Some people in Japan, for instance, will use tacrolimus. And there's a recent paper published this past month of tacrolimus in refractory MG purporting to see efficacious results. Again, a very small case series, and I think the numbers are too small, but the suggestion is there that tacrolimus may be beneficial in treating refractory MG. None of the mechanisms that we've talked about and none of these approaches can explain what we see here. And this is elegant work done by Andy Engel back in the 70s. And here on the left, we have a normal neuromuscular junction. Here's our nerve terminal. Here's the postjunctional folds. This dark, dense staining represents acetylcholine receptors that bind to the crests of these folds. And this architecture allows for increased receptor density and the safety factor of synaptic transmission. In contrast, here on the right, we don't see these architectural folds. They've been literally destroyed. And the question comes up as to why. And that riddle has been solved, as you all know, and it's due to the presence of a complement attack. So here in this upper left panel, we see IgG binding. We take that as a marker for antibody binding to the receptor complexes. And then in the debris field, we see intense staining here that represents the C9 portion of complement that reflects the architectural destruction that has occurred due to a complement attack. And what we now have worked out and understand, both in experimental models through the early 2000s and through our own clinical work, that antibody binding to the acetylcholine receptor activates the C1q complex of complement, which in turn initiates the classic portion of the complement pathway that ultimately leads to the formation of the membrane attack complex, which is composed of C6, 7, 8, and multiple copies of C9 that form a ring-like structure that literally drills holes into the membrane. We have ion leak and then destruction of the membrane itself. We now believe that complement-mediated lysis is the primary pathogenic mechanism in myasthenia. Back in the 90s, there was a group coming out of Yale that was looking at targets to treat paroxysmal nocturnal hemoglobinuria. They were able to identify that it too was a complement-mediated disorder and developed an antibody to C5. And what we're going to talk about forthcoming are ability to target C5 and then subsequently reduce the membrane attack complex and its influence. We call this the terminal component of the complement system. We leave intact with our therapies all of the proximal portion, so we're able to complete microbial opsonization. We're able to be activated through a variety of bacterial, viral situations. We still have chemotaxis and cell activation because this portion of C5a remains intact that we'll talk about in a minute. So we're going to focus here in this portion of the complement pathway. Much of the basic science data goes back to the mid-late 70s, and one is by Vanda Lennon, who had an experimental animal model and was able to demonstrate that receptor binding was preserved, receptor density was preserved, animals maintained body weight and did not get sick when they were treated with cobra venom factor, which depletes complement. Similarly, when I was doing work in our laboratory looking at passive transfer of human disease to our rats and then looking at the physiology, we could block the development of the experimental myasthenic rat by depleting complement with the use of cobra venom factor. And so it became, at least quite early, though we didn't fully recognize the importance of this, that complement was playing a crucial role in the development of experimental myasthenia. And here are some co-localization studies of Bunger toxin, antibody using IgG as a surrogate, and complement. And if we look at Bunger toxin binding and antibody, we see that they co-localize. Similarly, Bunger toxin and C3 co-localizes here. Bunger toxin, C1q, co-localizing. And Bunger toxin and C9, membrane attack complex, co-localizes. So we're able to establish there's a very intimate relationship of complement at the neuromuscular junction at the site of the acetylcholine receptor. If we target C6 one step downstream with a monoclonal antibody to rats who have EAMG, we can prevent the development of the experimental myasthenic animal by treating them with a monoclonal antibody to C6. And here's the EAMG wild type. He can't lift its head. He can't bear weight on his forepaws. There's a decremental response to repetitive stimulation, and he loses weight and succumbs to the disease. And weight has been often used as a marker of disease activity in these animals. Treating with a monoclonal antibody to C6, this rat looks up, alert, can bear weight. There's no decremental response, and he maintains weight throughout. Again, targeting the distal complement system, we're able to preserve health. Moving up one step to C5, and here's a monoclonal antibody, and here's an arbitrary clinical score. Worse is high, improvement or good is low. And if we use the experimental animal here, the wild type, he is sick. If we then treat with another monoclonal antibody against C5, we can prevent these animals from getting sick. And here on the right, here's the wild type in the open bars, the treated animals with anti-C5 in their clinical scores. And one sees that these animals here in the open bars are so sick by day 2-3 that they had to be euthanized for their own health. What we do know is so that we've targeted C6, we've targeted C5, and we can prevent the formation of the membrane attack complex and prevent EAMG. We now know that if we target C5a, we have no effect. And these animals are essentially the same, whether they're treated or not. They develop experimental myasthenia, weakness, the electrophysiology, immunology of the disease. So this is not a reasonable target for the disease. So I want to talk briefly about regain. And we'll go into some depth into some of the post hoc analyses that we've done as we've come to understand this more fully. We enrolled people who had failed multiple therapies or who had required chronic plasma exchange or IVIG. They had to have an ADL score of at least 6, which represents moderate impact on their disease. They had to have antibodies to AChR and mild to severe generalized weakness. And we looked at the change in the MG-ADL score at 6 months. These folks had long disease duration, on average around 10 years. They had a fairly high MG-ADL score that was well balanced. Their QMG score, another outcome measure we commonly use, was high as well, as was their composite and their quality of life instrument. Here's the disease severity by stratification. And you can see we're underrepresented in the severe, but predominating in mild and moderate disease. A means predominantly limb involvement. B means predominantly oropharyngeal bulbar involvement. And one sees that more than half of these patients had been treated with at least 3 immunosuppressive agents, and nearly 100% had experienced at least 2 in their disease course. About 30% had gotten previous IVIG, less than that in plasma exchange. I think this represents regional treatment differences, but 75 to 80% had had exacerbations of their disease. Nearly 20% had had an MG crisis. 3/4 had been in the hospital because of their disease. And one sees that a fairly sick disease burden in these patient populations. Let's focus here in the left side. This is the blinded portion of the study that we call REGAIN. Red is placebo, blue is active drug. And like all MG trials, we have a significant placebo effect that has been our nemesis. But one sees, despite this, a very rapid and robust improvement in the MG-ADL score that was measured here that appeared to peak somewhere between weeks 8 and 12 and then were sustained. When we took and then crossed them over into the open label portion, and this was done in a blinded fashion so that we didn't know who was still on what, one sees that those who are already on eculizumab, the blue, continued to maintain their degree of improvement. And those who have been on placebo follow a very similar course as the original ECU group with a very rapid, robust change that then parallels the original ECU treated group. We saw responses following 1 infusion, and this was administered weekly for 5 times and then every other week thereafter, using the weekly as a loading dose to get them inhibited in terms of complement function. And so I think there is no question that we're seeing a true drug response here with a very robust improvement. And we saw similar outcomes if we looked at the QMG, if we looked at the MG composite. The QOL, in fact, very similarly, although this slope was not as steep, but clearly they had meaningful, significant change very rapidly that persisted. And we have patients now who have been under treatment for almost 6 years and are still doing very well. About a year ago, we tried to ask why did only 70% of the population get better? And as we looked at these people in this open label portion of the study, there was a group of them, 17% of them, that were what we call late responders. So here's the original response: rapid, robust, sustained, that was seen by week 12 to 20. And then we have this group here that really doesn't start improving till somewhere around week 40, week 50. And only around nearly 2 years later do we see them start to approach the original group. We used to think that if you did not see a meaningful response by the 3rd or 4th month, you were not going to respond, you should stop the drug. And now we have to rethink all of this. And even though the numbers are small in terms of percent, there is a subgroup that has this delayed response. We don't know why. We've looked at all various characteristics with the data that we have available and all of the common things: age, disease duration, severity of disease, which domains are involved. We cannot find a reason why we have this group with a delayed response. So now we think you probably need to treat for 6+ months. And if you don't see any response by then, it's probably reasonable to discontinue therapy. The other interesting feature that we've seen, and remember, these are patients who had significant disease, having failed multiple forms of therapy. The red is placebo, the blue is the treated arm, And as I said, after 26 weeks in the blinded fashion, we have about 60% who are better. And then as we go into open label, this improvement continues to now involve up around 85%. And here's the placebo response here. They switch over to eculizumab in this group 2 over 130 weeks. About 90% of them get better. What's even more impressive is that what is in yellow. And this is called minimal manifestations. And so this is a clinical decision by the physician that the individual has minimal weakness, if any at all, that does not interfere with any function in life. And so by the end of the blinded phase, we had 25%. The treated arm, much less than that in the placebo arm. But look what happens as we go. Nearly 50 to 70% of these patients are achieving this state of minimal manifestations 130 weeks down the road, having failed everything prior to entry into the study. And I think this is telling us that complement inhibition is playing a critical role in controlling one of the more critical elements in the pathogenesis of the disease. Last year, we invented a new outcome measure called minimal symptom expression. And this are individuals with an MG-ADL score who have a 0 or a 1, which is essentially is no significant impact on life. And one sees that over time, this increasing number of these patients, again, who have failed everything, achieving this MSE, if you will, marked improvement. When we looked at exacerbation rates, and here is the 2 years prior to going into, or 1 year going into the study, in terms of patient years, 75% reduction treated with eculizumab. Here's the placebo arm here in the middle. But marked improvement in the disease or the capability of preventing exacerbation rates of their disease. When we look at hospitalization rates, again, more than 80% reduction in the need to be hospitalized for activation of the disease, exacerbation of the disease, while treated with complement inhibition. And then when we look at deterioration, here are those who are Soliris responders. In that arm, 65 patients, 1 exacerbation, 1 rescue therapy. Here's placebo, 20 of them. And here are the non-responders, somewhere in the middle. So they may have had a partial response, but not a significant one, and they fall in between. Safety, most commonly, mild headache treated with a nonsteroidal or acetaminophen, nasopharyngitis, a little diarrhea, but all in all, very well tolerated. There were 2 deaths unrelated to the treatment itself. One occurred 3 months after discontinuation from the study because of complications related to a crisis, and one had hepatic failure. I think it was due to a CMV, a virus which was felt not to be related. During the study, there were no meningococcal infections. Through the post-open label, we've had 2 meningococcal meningitis, both treated successfully with no deaths there. And so a very safe profile in our experience, though not without risk. And all of these patients must be immunized against meningococcus. And we're using 2 vaccines, the quadrivalent plus the B serotype as a protection. And it must be given 2 weeks before receiving a complement inhibitor. So we now have approaching 60,000 patient years of experience, and we've picked up no new signals whatsoever. I want to switch a little bit and talk about a new therapy that is still under trial. This is called zilucoplan. This is a small molecule. It's a macrocyclic peptide that targets C5. It's administered subcutaneously on a daily basis. It's a little more than a half a cc aqueous injection. The entry criteria was similar, except there was no requirement to be refractory. So we took all comers. And because it was phase 2, we looked at the QMG score, change from baseline. Because of the regain data that I just showed you, we changed the duration of the study from 26 weeks to 12 weeks because we thought we'd see a meaningful response. The phase 3 trial, which is using the ADL score as the primary endpoint, is ongoing at this time at multiple sites throughout the world. So 44 patients were randomized, and we looked at 2 different doses, high dose, middle dose, and placebo, 0.3, 0.1 per kilogram in placebo on standard of care therapy. Again, similar to the regain, patients had received, in some instances, multiple drugs, but there was no one who was refractory. But unlike regain, nearly 10% had never seen steroids, 25% had never been on an IST, nearly 50% had not seen plasma exchange. So this is more real-world, common-day myasthenia that we see on an everyday basis. Their metrics, if you will, their demographics, baseline characteristics were quite similar to what was in regain. QMG here, fairly substantial, ADL score, a little bit less than regain, but still representing a high unmet need. If we look at the zilucoplan levels in plasma, here's placebo, here's the 0.1 per kilo, 0.3, clearly more drug, which you'd expect, but here's complement inhibition, which is more important. No inhibition in the with a placebo. Here in red, full complement inhibition. We're down at non-detectable levels, and not quite so well here. And for this reason, we've chosen to use the higher dose in the phase 3, and I'm just going to show you data with the high dose in our phase 2 study. This looks just like the regain. The time plot is different, so the slopes don't look as impressive, but here, treated in red, blue is placebo. Again, our placebo response, but a rapid, robust, sustained improvement over time. Remember, these are small numbers, 7, 13 in each arm out here, 15, 14 at the end of the blinded phase, still demonstrating significance. Here's the ADL score. This one is the QMG score. And a very similar process is seen. If we look at it a different way, what I call the Christmas tree responder analysis. And so here is our QMG score, who had a 1-point change, 2-point change, 6, 9, 12, etc. And here, if you got worse, and we assume, or based on literature, a 3-point change is clinically meaningful. One sees that as we make this more stringent, there is a continued shift to the left, demonstrating improvement for the drug. And only those on placebo got worse in this clinical trial. Here's this minimal symptom expression, MSE, that we talked about before. Here's placebo, here's the 0.3 dose, nearly 40%, somewhere in between with the low dose drug. And so, again, this is a regain achieving minimal symptom expression using QOL here on the right, ADL score. And again, here's active treated arm. Here is placebo arm in the regain trial. And then as they convert over, the original placebo now becomes gray. And again, failing everything previously, a quarter of our patients were able to achieve virtually no symptoms whatsoever. And so we've made progress. We now have targeted immune suppression. And the targeting is reducing our side effect profiles without question. We have a tool that we can now treat a refractory population in, but we still have some work to go. We need something that would work for pending crisis or crisis. The speed with which we see a complement inhibitor work may suggest that we could use that. We need different formulations. We're partially there. We now have an IV preparation that's approved in the US and Europe and Japan. We have a subcutaneous preparation that's under trial. ECU is administered every 2 weeks. There's a companion product by the same company where it's an every 8-week administration. And we'll see how good it is. That is nearing completion for its phase 3 trial. There's talk of developing an oral compound of zilucoplan, which would be great. And so we wouldn't need any of the other. There are subcutaneous preparations that are coming. And I think these are important because it allows patient choice. We need therapy in our childbearing pregnant patients. There's data coming out of Britain based on the PNH studies that eculizumab is safe during pregnancy. The company's not going to tell you that at this point in time, but the published papers suggest that it is safe in women of childbearing age or during pregnancy. And we need a drug for the pediatric population. Eculizumab is currently under trial in a pediatric population, age 6 to 18, right at the moment. There are 6 patients enrolled. We've just screened number 7 this morning, and we're looking for 12. And this is a mandate of the European Medicines Agency that we have to show data in pediatric populations, and that's why that is going on. So there's no question we've made progress. There's no question we need to do better. But we now have something that we can use with much better side effect profile, much more rapid response, and much more durable response. It's my understanding that eculizumab is not available in Egypt yet, from what I was told the other day, but hopefully we can convince the ministries that this is a valuable tool to be used in treating the patient with myasthenia who doesn't do well. And with that, I will stop. I will turn this back over to Professor Said, and we'll go on with the next speaker. Thank you very much for the invitation. Truly enjoyed it. This is where Sama was 20 years ago, 25 years ago. He probably doesn't recognize it. This is all new. This is the cancer wing. The neuroscience center is behind. So,
okay, great.
Thanks again.
Great. Thank you very much, Dr. Howard. It's very illustrative, very advanced, and I think all of the audience has benefited from your experience in this very difficult group. I think we'll shift now to our eminent next speaker, Dr. Amato. Dr. Amato is the Brigham and Women's Hospital Distinguished Chair in Neurology. He is the Chief of the Neuromuscular Division and Director of the Clinical Neurophysiology Laboratory at Brigham and Women's Hospital in Boston. He is also a professor of neurology at Harvard Medical School. He was elected by his peers to be in the chair of the neuromuscular section of the American Academy of Neurology, April 2011 to April 2013. He founded the Harvard Partners ACGME approved neuromuscular medicine fellowship program, the largest such training program in the country. Previously, he started and directed the Partners Clinical Neurophysiology Fellowship. Dr. Amato is an author and co-author on over 300 published articles, chapters, and books. He co-wrote chapters on muscle disease, peripheral neuropathies, and neuromuscular junction disorders in the most recent editions of Harrison's Principles of Internal Medicine, and has written one of the leading textbooks in the fields called Neuromuscular Disorders. He's an associate editor of neurology. He has been involved in clinical research trials involving patients with amyotrophic lateral sclerosis, peripheral neuropathies, neuromuscular junction disorders, and myopathies, including trials in patients with muscular dystrophy. dermatomyositis, polymyositis, and inclusion body myositis. I'm honored to introduce you Dr. Amato, and please, you have the stage.
Thank you. So can you see my slides?
Yes, it's clear.
Okay, good.
Please, go ahead. Yeah.
So I'll talk about the idiopathic inflammatory myopathies. No disclosures. And the goal is so that everybody can understand better the clinical, laboratory, and histopathologic features of the inflammatory myopathies, and the update the different pathogenic bases of these disorders. The specific idiopathic inflammatory myopathies that I'm going to discuss are dermatomyositis, polymyositis, autoimmune necrotizing myopathy, inclusion body myositis, and antisynthetase syndrome. I'll start with dermatomyositis. This can present at any age, including childhood. Like other autoimmune diseases, women are more commonly affected than men. Onset of weakness is usually, it can be acute or it can be insidious. Affects proximal distals more than distal in a symmetric pattern. There's a rash that can accompany or precede or sometimes follow the onset of weakness. When it follows the onset of weakness, people might be misdiagnosed as having polymyositis, and I'll show examples of the rashes that one can see, but there's the heliotrope, which is the rash over the eyelids, a shawl sign, so the back of the neck and shoulders, a V sign over the anterior region of the chest. We have Gotrin's sign, which is a rash on the extensor surfaces of the hips, knees, ankles, and elbows, and knuckles. And Gotrin's papules is where you have raised rash on the knuckles, and then there's nail bed changes. And then some patients have a rash with none or very little weakness, and we call this amyopathic or hypomyopathic dermatomyositis. These are typically treated by dermatologists more than neurologists or rheumatologists. Here we can see a rash on the forehead and the cheek, and this lady, here's a heliotrope, so you can see the rash on the eyelids accompanied by periorbital edema. This is, again, a child with juvenile dermatomyositis. She has a rash all over, but exhibits a nice V sign over the anterior neck and chest. This example of erythema, flat erythema in the knuckles. Sorry. Which is a Gotrin sign. And when there's raised papular rash on the knuckles, that's Gotrin's papules. Can also appreciate some nail bed changes, some cracked skin at the nail beds, and then dilated capillary loops, telangiectasias, that we see with dermato. In higher power, you can see the dilated capillary loops. You could also see some necrotic lesions that you see because it's a vasculopathy. You can get ulcerations going on. One can see calcifications. They occur over pressure points in the buttocks, knees, and elbows associated with inadequate treatment. Here's an example, kind of nasty calcifications on the knees. They can erupt, get infected. You can do surgery and excise them, but they often come back. So the best treatment is prevention. Aside from skeletal muscles of the extremities, other muscles can be involved in organ systems, including the gastrointestinal system, the oropharyngeal. So oropharyngeal muscles can be affected, leading to dysphagia in as many as 30%. You can have even masseter weakness leading to chewing difficulties. Sometimes there can be dysarthria from oropharyngeal and tongue involvement. And you can get an ulcerations of the gut, again, from the vasculopathy leading to GI bleeds. The cardiac muscle can be affected. Again, overt cardiac symptoms are rare, but some patients can manifest symptomatically with a pericarditis or myocarditis, manifesting either as an arrhythmia or congestive heart failure. Again, it's about a 5% manifest with symptoms, so you got to watch out for that. The lungs can be affected by multiple mechanisms. One is aspiration pneumonia from the oropharyngeal weakness. Ventilatory muscles can be affected, though rare, but maybe 5%. More common is interstitial lung disease, interstitial fibrosis. Many of these cases are associated with antisynthetase syndrome, and as I mentioned at my initial slide, the antisynthetase syndromes now are thought to be a separate inflammatory myopathy, but you'll still see a literature of antisynthetase antibodies or dermato or polymyositis, so I will mention that here. But you can have interstitial lung disease and dermatomyositis without antisynthetase antibodies. Joints can be affected, so there can be joint pain with or without frank arthritis. It's symmetric, affects proximal and distal joints. Pain is eased by passive flexion, so you really need to get into early PT so kids don't kind of just stay flexed and get fixed contractures. There's an increased risk of malignancy with dermatomyositis. Epidemiologic series that have been published, I've seen it range from 6 to 45%. Most good studies within the more recent literature suggest the risk of between 10 and 15% within the first 2 to 3 years. It's seen in the adults, usually over the age of 40, so the juvenile dermatomyositis is not associated with an increased risk of cancer. The risk of malignancy does not correlate with the severity of the myositis or the dermatomyositis or the skin rash. And treatment of the malignancy can improve the dermatomyositis, and that's because many of the chemos that are used suppress the immune system, but often we need to treat the dermatomyositis independently, say with IVIG, gamma globulin. So all patients with dermatomyositis should get, or at least adults should get, a malignancy workup. We don't need to do this in young kids. It should include pan scan of the chest and abdomen and pelvis, breast exams, pelvic exams, testicular ultrasounds, colonoscopy, and mammograms. And just because you do a malignancy workup and you don't see a malignancy, that doesn't mean you don't have to worry about it in years to come, because again, the risk of malignancy is within the first 2 to 3 years of onset of the dermatomyositis. So you need to be vigilant for signs. It doesn't mean you need to do pan scan patients every 6 months, but you need to be vigilant and listen for signs that they may have developed a malignancy. In terms of laboratory workup, the creatine kinase, or CK, is the most specific marker of muscle destruction. It's elevated in about 70% of dermato, but again, that tells you that about 30% of dermato can have a normal CK. About 10% of those patients will have an elevated aldolase. So that's where aldolases can be useful. The level of the CK doesn't correlate with the severity of the muscle weakness or the rash. Anti-nuclear antibodies may or may not be present, and there can be some myositis-specific antibodies that are useful in regards to predicting response to therapy and prognosis. In regards to the myositis-specific antibodies, I mentioned antisynthetase antibodies, Jo-1 being most common, but again, we now believe that those with antisynthetase antibodies and myositis is a separate category altogether, but there are some antibodies that are specific for dermatomyositis. Anti-MI2 is present in about 15 or 20% of dermatos associated with an acute onset florid rash, and usually a good response to treatment and prognosis. Antibodies to CADM140 or MDA5, or melanoma differentiation associated protein, is again seen in about 10 or 20% of dermato, often seen in patients that have clinically amyopathic dermatomyositis or hypomyopathic. So they have a lot of skin changes, but not much muscle involvement. They often, though, have severe interstitial lung disease and skin changes. And the skin changes not only involve the dorsum, but also involve the palmar surface of the hands, which is a clue, and severe ulcerations. It's more common in Asians, but it can be seen in other populations. Laboratory-wise, it's also associated with very high ferritin levels. So that's a biomarker for this specific disorder. Here's a patient I saw. Again, very severe rash, not only on the palmar surface, but again, you get gangrene, distal ulcerations. This patient happened to had a real severe disease and died from interstitial lung disease within about a month. So they can be very nasty. TIF1 gamma antibodies, also known as P155, are seen in about 90% of dermato that's associated with cancer. So it's a good clue. So when I have this antibody, then I often will also get a PET CT. Antibodies to nuclear matrix protein are also seen with cancer, though not as high of a prevalence as you see with TIF1 gamma. There is a higher association, though, with calcinosis and subcutaneous edema. And patients also have been reported that often have prominent, aside from the proximal weakness, have finger extensor weakness. Again, the pitfalls are that the antibodies haven't been associated or studied prospectively. They're not pathogenic in and of themselves and may represent an epiphenomenon, but they're very helpful in classifying subtypes of inflammatory myopathies and their prognoses. EMG can show a triad of increased insertional and spontaneous activity in the form of fibrillation potentials, positive sharp waves, complex repetitive discharges, and early recruitment of small myopathic units. But again, none of these are specific for dermato. We can see it, and they're not specific for an inflammatory myopathy. They're really seen in any kind of myopathy in which there's muscle membrane irritability. Muscle imaging can be done, MRI or CT scan. Radiologists like to call any kind of edema on muscle myositis, but again, all it is edema. You can see edema from any type of inflammatory myopathy, but also toxic myopathies, muscular dystrophies, and even acute neurogenic atrophy. Sometimes you could use the imaging studies to guide a muscle. I usually don't. I usually just use my clinical exam and biopsy a muscle that's clinically weak, but not too weak, or use my EMG also to help guide. But in those cases in which maybe weakness is only in hip flexors or hip abductors, and we usually don't biopsy an iliopsoas or gluteal muscle, MRI and EMG can be helpful in guiding biopsies sites. Here's an MRI showing edema in the quadriceps, less so in the hamstrings. With treatment, you'll see less edema or inflammation. A muscle biopsy, the characteristic feature is perifascicular atrophy. You can see some small scattered infarcts. Those are rare. It used to be thought that the perifascicular atrophy was from ischemia, but that is now known not to be the case. Inflammation, when we see it, is perivascular and predominantly in the paramecium, is composed of macrophages, B cells, and CD4 cells, which were thought to be mainly T helper cells, but now we know that they're mainly plasmacytoid dendritic cells. We don't see much in the way of endomysial inflammation and invasion of non-necrotic muscle fibers as we do with polymyositis and inclusion body myositis. Early on, we also see a reduction in capillary densities. A couple decades ago, it was appreciated that you can have immunoglobulin deposition on small blood vessels and complement, as Chip mentioned, complement seen in neuromuscular junction and myasthenia. And you do see this, and it was thought that dermato was an immune-mediated complement microangiopathy causing ischemia, but that is not the case. That the deposition of complement and immunoglobulin is secondary in dermatomyositis on just abnormal muscle membranes. We do see on electron microscopy endothelial hyperplasia and cytoplasmic inclusions in the blood vessels. And these changes precede perifascicular atrophy. This is an example of perifascicular atrophy. We see the fibers at the edge of the muscle fascicles are smaller in diameter than the ones in the center. That's the perifascicular atrophy. The inflammation is around blood vessels, and it's in the paramecium, not the endomysium. The issue with this is, though this is pathognomonic for dermatomyositis, you're only seeing about 50% of time. It's a later phenomenon, so if you're attuned and make a diagnosis really quick, you're not going to see this. What you may see is complement, as I mentioned, on capillaries. You might see, if you do special capillary stains, a reduction in capillaries. There should be one capillary for every fiber, and you see a marked reduction here. And then some remaining capillaries can be dilated. So there is a vasculopathy. You can also see COX negative, SDH positive on perifascicular fibers. So there's a mitochondrial abnormality in these perifascicular fibers as well, all secondary though. This is a major histocompatibility. One, normally muscle fibers do not express MHC1. Capillaries do, but not muscle fibers. So when you see MHC1, which is kind of this brownish stain on muscle fibers, particularly on the sarcolemma, that's abnormal. It's seen, it indicates that there's an immune process going on. You could also see it in regenerating fibers, but here we're seeing it mainly in the perifascicular fibers, and we're seeing it before there's any kind of atrophy. And again, we see this here. I was long interested in looking at molecular profiles and worked with a colleague, Steve Greenberg here, and I sent him all my muscle biopsies that I did to do RNA sequencing and see if there was a genetic signature that we could see that might help with diagnoses. And we found out, looking at the genetic signatures, that we could separate normals from inflammatory myopathies, from congenital myopathies, from muscular dystrophies. And even when you look at the inflammatory myopathies, the dermato would separate out from IBM and poly. And on this heat map, the red is very highly upregulated genes. And we see in dermatomyositis that the most highly upregulated genes expressed in muscle are type 1 interferon inducible genes. One such is MYXO-associated resistant protein, or MXA. It's type 1 interferon protein. And doing immunostains for MXA, we could see that there was, like MHC, you could have either diffuse expression or expression just on the perifascicular muscle fibers. Not only do we see it on muscle fibers, it's seen in capillaries, and you should not see it in capillaries. And this is specific for type 1 interferon. So other type 1 interferon inducible genes like ISG15, IRF7 show positive staining in fibers and vessels, but gamma interferon just shows in inflammatory cells, but not in muscle. So this is really specific for type 1 interferons. I mentioned, like if you do electron microscopy and you look at endothelial cells, there's thickening and tubular reticular inclusions that are seen in endothelial cells. If you grow endothelial cells and culture and you expose them to type 1 interferons, you will get the formation of these tubular reticular inclusions. What makes type 1 interferons? Well, the major producers are plasmacytoid dendritic cells. And as I mentioned, there are a lot of CD4 cells in dermatomuscle cells, and people thought that they were T helper cells. But when you look at it closely, they're CD3 negative, so they're really not T cells. And you look at the appearance, sometimes they have this dendritic appearance, sometimes they have this plasma cell appearance or plasmacytoid. And doing special stains, we were able to show, Steve Greenberg again, who I worked with, showed that these were plasmacytoid dendritic cells. And in the plasmacytoid phase, they're filled with interferons. Interestingly, if you look at skin biopsies in patients with dermatomyositis, also with lupus, this is kind of representative of what you see in muscle biopsies. Dermatopathologists will call interface dermatitis is kind of analogous to what we see in the muscle biopsies, where we in the muscle biopsies see inflammation in the paramecium adjacent to the perifascicular muscle fibers and damage to the most peripheral perifascicular fibers close to the dermis and or close to the paramecium. And dermatomyositis, you see plasmacytoid dendritic cells in this interface, and it's that basal layer of keratinocytes which are abnormal, atrophic, and damaged. Furthermore, if you do MXA staining on the skin biopsy, you see this orangish staining of the basal layer of keratinocytes that are damaged, much akin to what we see in muscle fibers. And so again, also, it's not these most basal layer of keratinocytes that are closest to the blood vessels that are the watershed area. It's the more superficial skin cells, keratinocytes, which are the in the watershed area, and there's not the one that are damaged. So again, this isn't from ischemia, but rather we think it's a diffusion defect, as it's closest to the type 1 interferons that are being secreted by the inflammatory cells, and so it's an effective diffusion that we see this. We also see the same expression pattern if you look at the peripheral blood. So if you look at peripheral blood, type 1 interferons are the most highly upregulated genes in peripheral blood. And if you follow patients clinically looking at type 1 interferon-inducible RNA expression and look at how they do clinically, those that do well clinically typically have a reduction in the type 1 interferon expression, while those that are refractory don't change or increase. So the pathogenesis of dermatomyositis is now thought to be related to these plasmacytoid dendritic cells and also the fibrocytes in the paramecium that also secrete type 1 interferon, and probably by diffusion. These are toxic. They're toxic to the blood vessels when it's too high and in the closest muscle fibers. The trigger is unknown, but we do know that viral infections with particularly RNA viruses and also naked DNA that you can see with cancers binding to toll receptors will cause secretion of type 1 interferons. So that kind of ties in that pathogenic basis of why cancer might be related. Most patients respond well to treatment. Those poor prognostic features are when you have an underlying malignancy, interstitial lung disease, heart involvement, or there's been very late or inadequate treatment such that patients, a lot of muscle fibers have been damaged before adequate treatment has got started. Moving on to polymyositis, I wrote this editorial with Robert Griggs almost 2 decades ago when he was editor of neurology and subsequently became the president of the American Academy of Neurology. And it was not so much to say that polymyositis doesn't exist, but that it's way overdiagnosed. I do think that there is this entity of this. I think it's a hodgepodge. It's quickly evaporating because we're calling more things that were called polymyositis. We're separating them into autoimmune necrotizing myopathy, antisynthetase syndrome, and inclusion body myositis is getting more and more recognized. It was frequently misdiagnosed as polymyositis. One of the reasons is Bowen and Peters criteria, which was developed in 1975 and published in New England Journal of Medicine, didn't even require a biopsy to make a diagnosis of probable polymyositis. And the only thing that distinguished dermato from poly was the presence of a rash. This is Bowen and Peters criteria. If you had symmetric weakness, a high CK, and cells that showed some phagocytosis and an EMG showing myopathic features, you can have polymyositis. And if you had a rash, you had dermatomyositis. Well, everybody we see, or just about everybody we see in our muscular dystrophy clinics will meet Bowen and Peters criteria for dermatomyositis. And they didn't even recognize inclusion body myositis at the time. So there is this small vanishing category of polymyositis, but I think it's a hodgepodge. Again, it's an adult symmetric proximal weakness without a rash. They can have dysphagia, heart, lung abnormalities, and arthritis, like I said, for dermato. Papers have suggested that the risk of malignancy is lower than dermato, but higher than the age-matched population. I think the risk is probably just as high. It's just older epidemiologic series included patients that had IBM and muscular dystrophies, which there's not an increase of malignancy. So again, you have to do a malignancy workup in patients with polymyositis. CK should always be elevated. SET rates are usually normal. It doesn't help. ANAs can be present in some patients. And again, that pushes me to look for an overlap syndrome. Again, you can have an abnormal EMG and muscle MRI, but none of these findings are specific. Muscle biopsy can show necrotic fibers, regenerating fibers, and endomysial inflammation. We like to see invasion of non-necrotic fibers expressing MHC1. When you see this, it's either going to be IBM or poly. Usually it's going to be IBM. If you just look at any kind of endomysial inflammation or perivascular inflammation, that increases the sensitivity, but not the specificity is reduced, because you can see, again, inflammation and toxic myopathies. You can see it with metabolic myopathies in which there's rhabdo going on. You can see it even with some dystrophies. The inflammatory cells in polymyositis are mainly macrophages, while in IBM it's mainly CD8 T cells, which can be helpful. T cell repertoire in polymyositis, so when you do see it, it's restricted, suggesting it's an oligoclonal driven response. We don't see membrane attack complex or immunoglobulin on vessels or like we do with dermatomyositis. Here we see an H&E stain, endomysial inflammatory cells surrounding non-necrotic fibers and invading non-necrotic muscle fibers. Here we have an MHC1 staining, so expressed on the sarcolemma of muscle fibers and inflammatory cells invading muscle fibers. Again, we like to see this, but again, this is actually much more common in IBM than you see it in polymyositis. In our studies and expression studies, we did see increased type 1 interferons in muscle biopsies, but not to the extent that we saw with dermatomyositis. So the pathogenesis basis of this shrinking disorder is that it's an HLA-restricted antigen-specific cell-mediated response directed against some unknown antigen or antigens on muscle fibers. We don't know the trigger. Viruses have been speculated, but we don't know. Again, most patients with poly, and I would say all patients with poly, should respond to immunotherapy like dermato. Some studies, retrospective studies, suggest that doesn't respond as well as dermato, and I think that's wrong. They do respond. It's just those patients that don't respond are probably going to have IBM and were misdiagnosed or a muscular dystrophy of some sort. If they don't respond, then you have to think about these other entities. Poor prognostic features, again, would be interstitial lung disease, heart involvement, later inadequate treatment. I mentioned antisynthetase or SRP, but those are now known to be different diseases, as I'll talk about. Overlap syndrome is when you have an inflammatory myopathy with another well-defined connective tissue disease like scleroderma, mixed connective tissue, lupus, Sjogren's, or rheumatoid arthritis. I won't say anything more about that. I did mention that I think that antisynthetase syndrome is now thought to be a separate entity. So we don't think you have dermatomyositis with an antisynthetase or polymyositis with an antisynthetase syndrome. It's its own entity. It can have, the main clinical features are proximal weakness. They can have interstitial lung disease, Raynaud's syndrome, and a polyarthritis. They may have mechanic hands, fever, and some patients have a rash. So that clinically it might mimic dermatomyositis, ergo the problem with the misdiagnosis. Other issue with a misdiagnosis with dermato is they can have a lot of perifascicular muscle damage. They can have atrophy. They tend to have more necrosis, though, than dermatomyositis. You can have edema and fragmentation of the perimesial connective tissue and alk phos staining. We see this with dermato also. You can have MHC1 staining in the perivesicular regions, as just had with dermato. What you don't see, or what you see with antisynthetase that we don't see with dermato, is membrane attack complex, so much on non-necrotic muscle fibers. So that we don't see so much of, or MXA staining. So here's an H&E stain. And again, you can look at that and you can say, okay, the fibers at the edge, the perivesicular fibers are smaller than some that are in the center. So there is this perivesicular atrophy, but there's a lot of necrosis also going on, which we don't see as much necrosis going on with dermatomyositis. There's a lot of paramesial edema and fragmentation. You can't see that to an extent though with dermato. It's just more, you can see alkaline phosphatase staining of which is kind of this bright red, and this stain and the paramecium, but you can't see that to some extent with dermato. Here's membrane attack complex. So we see membrane attack complex in the paramecial connective tissue, and also on the sarcolemma of non-necrotic fibers, particularly the perivesicular fibers. And that's something that can help make you think, okay, maybe we're dealing with an antisynthetase syndrome. Also, what you see in antisynthetase syndrome on electron microscopy is actin filaments and myonuclei. You don't see this in dermatomyositis. Autoimmune necrotizing myopathy can resemble polymyositis with symmetric proximal weakness and very high CKs, though. Usually the CKs are 5 to 15,000. It can be associated with cancer, connective tissue, or interestingly, statin use. So it's not the kind of statin myopathy that we were all taught that, you take a statin, you get myalgias and a little bit of a high CK. If you stop the statin, it gets better. These are patients that have weakness, very high CKs with statin. You stop the statin 2 weeks, 2 months, even 6 months or a year later, they're still very weak and high CKs. And they only get better when you treat them with immunotherapy. They had a hard time having anybody believe me that statin was a trigger for this until, and I published it in Muscle and Nerve, 25 such cases, but people didn't believe me. It wasn't until the Johns Hopkins folks found the same thing and detected an antibody, interestingly, HMG-CR reductase, which is the enzyme that statins inhibit. And these antibodies are seen in about 70% of patients with an autoimmune necrotizing myopathy. About 10% of cases have antibodies to anti-signal recognition particle, or SRP, and about 20% there's no antibody. Some of those are related to cancer, connective tissue. Some are still idiopathic. And it's important that you could also see HMG-CR antibodies in patients that have no history of exposure to statins. It can also manifest in childhood, and these patients can look like a limb girdle dystrophy, even have scapular winging. And the biopsies can show a lot of dystrophic changes too. And it's important because this can be treatable. So again, another pearl, if you have a patient with a limb girdle muscular dystrophy syndrome and you do genetic testing and you don't see any genes, mutations, to check for HMG-CR antibodies, because you might have something that's treatable. Biopsy typically shows scattered necrotic fibers. You might see thickened pipe stem. They might have membrane attack complex on the capillaries. There can be patchy MHC1 staining and patchy membrane attack complex staining as well. The important thing is that HMG-CR, it used to be that we in most cases they're often very refractory, often need to do prednisone and methotrexate, often IVIG or Rituxan. But in the HMG-CR cases, it was shown that they can be responsive to monotherapy with IVIG, and about 70% of my patients and those in the Hopkins series are very responsive to IVIG alone. And so this is a very important observation. This is a biopsy. Again, necrotic fibers and inflammation that's really confined to myophagocytosis of necrotic fibers. We can see membrane attack complex on necrotic fibers and capillaries. MAC staining can be on necrotic fibers diffusely, but on the sarcolemma of non-necrotic muscle fibers, show a good biomarker of an autoimmune necrotizing myopathy. MHC1 staining normally stains capillaries, but again, when you see it on the sarcolemma of non-necrotic fibers, think of an autoimmune disease. It can also be seen on small regenerating fibers. So if it's only seen on small diameter fibers, as you see here, this could be just from regeneration alone. So you don't want to overcall it autoimmune necrotizing myopathy if only seen on regenerating fibers. Moving on to my last topic, it's inclusion body myositis. It's frequently misdiagnosed as polymyositis. Very slow, insidious onset. Average duration of symptoms is about 6 or 7 years before a diagnosis is made. Unlike the other myositis that I've discussed and most other autoimmune diseases, IBM affects men more commonly than women. It usually develops over the age of 40, most of the time over the age of 50, and it's probably the most common muscle disease other than just sarcopenia of the elderly that you see in people over the age of 50. Clinical hallmark is that there's often early weakness and atrophy of the quadriceps muscle and the legs and the flexor forearm muscles, so the wrist and finger flexors in the arms, such that often the quadriceps are as weak or even weaker than the hip flexors, and the deltoid muscles are often relatively spared, but the wrist and finger flexors are weaker, particularly the deep finger flexors of the thumb. About 2/3 of patients have this pattern of weakness. So when you see it, it's pretty specific, but about 1/3 of the patients won't have the pattern. They could look like a poly or dermato or necrotizing myopathy with hip girdle weakness. Other times I've seen it with a head drop, or sometimes they'll present with dysphagia. But when you see this pattern of weakness, it's pretty pathognomonic for IBM. Best way to look for the atrophy of the forearms is with the arm semi-pronated, and you can see how it's atrophied, the forearm. The hand intrinsics are spared. It often affects the medial aspects of the forearm. Here I'm asking the patient to flex both hands, the fingers on both hands. You can flex them somewhat in this hand. The little finger doesn't flex. Here it's much weaker. Doesn't flex the distal fingers at all, including the thumb. Again, aside from polymyositis, I've seen this misdiagnosed as motor neuron disease or amyotrophic lateral sclerosis, ALS. And again, why? Because there's asymmetric weakness and atrophy and weakness of the hand intrinsics. But the pearl is that in ALS, and all you know is motor neuron disease, there's a lot of atrophy of the hand intrinsics. In IBM, the hand intrinsics, the bulk is okay. The atrophy is in the forearm. In the legs, there's atrophy of the quadriceps, weakness in knee extensors, and ankle dorsiflexion. Another reason for the misdiagnosis of ALS is they sometimes have this Babinski sign. It's really a pseudo-Babinski sign. The reason the toe goes up is because toe flexors are also weak. And they're weaker out of proportion to the toe extensors. So the toe kind of stays in a status upgoing sign or Babinski sign, but it's really not. It's just up because the toe flexors are weak. Ankle dorsiflexors are weak also. Muscle weakness is often asymmetric. Facial weakness is common. And dysphagia can be present in 60%. Rarely it can be the presenting manifestation. So I often will see ENT doctors refer patients now. And again, something I think about aside from myasthenia gravis or ALS, I do think about IBM and somebody that's presenting with dysphagia. Sometimes the dysphagia is severe enough to require a cricopharyngeal myotomy or dilation. Here's a swallowing study, and you see this hypertrophic pharyngeal muscle or cricopharyngeal bar. Sometimes I've seen radiologists call this a posterior osteophyte. It's not an osteophyte coming off the spine. It's just fibrosis of the cricopharyngeal muscle. So you have to do dilations or even a myotomy. And sometimes they're good for 2 to 3 years, but often the dysphagia comes back and they need to get redilation. There's no risk of myocarditis or interstitial lung disease, no increased risk of malignancy. Some autoimmune diseases like Sjogren's, and particularly granulomatous myositis or sarcoid, about half the cases, if you do biopsies and show granulomas and they get diagnosed as having sarcoid or granulomatous myositis, about half those cases will turn out to be IBM. CK is normal or only mildly elevated, usually less than 10 times normal. ANA can be elevated in about 20% of patients. Muscle MRI and ultrasound can be useful at times. A muscle MRI, this is with stir imaging. So the stir imaging shows inflammation, edema is bright. You see it, and there's increased inflammation in the vastus medialis and lateralis with sparing of the rectus femoris, and much more so than the posterior biceps femoris. So this feature is something that should suggest IBM to you. This is an ultrasound of a forearm. Here's the skin. Here's the flexor digitorum superficialis and the flexor digitorum profundus, and then the humerus, which is very hard to, or not the humerus, your forearm muscle, forearm bones, all in radia. You can hardly see it, and it's because it's so echogenic, so much fibrotically replaced the deep finger flexors compared to the superficial finger flexors, and you don't see, again, the bone, the radius, or the ulna muscle. So this pattern should make you think of IBM as well. Nerve conduction studies can show an axonal neuropathy. Again, that's not the main feature. Again, it's an older population, so some of the snaps may be reduced because of age. EMG can show large polyphasic units that can resemble neurogenic units, but it's not. It's not from neurogenic process, but from a lot of scarring of the muscle and splitting, so that it reflects chronicity of the disease and splitting of muscle fibers, that the units become longer in duration, polyphasic. And you can have hypertrophic units too. So if you get the needle right close to a muscle, it can be large in amplitude. Endomesial and muscle biopsies show endomesial inflammation. It's mainly CD8 T cells, and they invade fibers that express MHC1 antigen. You also see small groups of atrophic fibers. We like to see fibers with one or more rimmed vacuoles, and we may see eosinophilic cytoplasmic inclusions. The inclusions of inclusion body myositis are not the eosinophilic inclusions or the rim vacuoles that we see on light microscopy. They're the tubular filamentous inclusions that we see on electron microscopy, but we don't really do electron microscopy much anymore. We don't need to do that. There can be amyloid deposition that's seen, and I'll show you examples. I mentioned there's tubular filaments on EM, and there's a lot of mitochondrial abnormalities seen on trichrome and cytochrome oxidase stain, which I'll show. Here's an H&E stain. We see inflammatory cells invading fibers, have fibers with one or more blue rim vacuoles. Here at higher power, you see a fiber that has nice blue rim vacuoles on an H&E stain. On trichrome stain, there can be red rim vacuoles. But the important thing is, in about 20 or 30% of muscle fibers, you won't see rim vacuoles. Or you might see something like this. And you just scratch your head and say, do I call it? And again, and pathologists look at the literature, and the literature is full of pictures that look like this, because you put your best examples out on a paper or in a textbook. But often in real life, it's not this, it might be this, or it might be this, where they're absent. So 20%, 30% of the time, when you know the guy's got IBM, but you can't find the rim vacuoles on the biopsy. So in those cases can get misdiagnosed as polymyositis, particularly if you're not attuned and doing a good exam and looking for the deep finger flexors. We can also, so blue rim vacuoles, can also see some eosinophilic inclusions in the cytoplasm, sometime in nuclei. They can be hard to see because they're eosinophilic. And so again, sometimes you got to go on higher power on NH&E to find them. On Congo red, they can be difficult to see as well because it's the same kind of coloration as the fiber. But if you look under a rhodamine optics Texas red filter, it'll show it as bright red. Or you can look under polarized light and look for amyloid. The biggest mistake pathologists make is they look for amyloid. Traditionally, pathologists, when they're looking at for amyloid in other tissues, they look at it in paraffin sections. But in IBM, the process of paraffination gets rid of the amyloid that you see in IBM. You only see it in frozen sections in IBM. And most pathologists don't look at the initial papers that have said this. They look at their own experience of looking at amyloid in the kidney or fat and looking at paraffin. And they say, well, there's no amyloid, so it's not IBM. But it's got to be only seen in frozen. And you see it here. But they're still very, very difficult to see. You might see it in only 1% of muscle fibers, and they're very hard to find. Now we do immunostaining to P62, and this has been found to be the most sensitive marker looking at inclusions in the cytoplasm. It stains the sequestome. So you see these dense little inclusions, these dense inclusions in IBM. If it's finely speckled, you can see finely speckled in necrotic muscle fibers, but that doesn't count. You want to see these dense inclusions, and that's relatively specific. EM, as I said, shows myeloid debris and filaments in the sarcoplasm, filaments in myonuclei. The inflammatory cells are mainly CD8, CD3, so they are T cells, cytotoxic T cells. There are dendritic cells, but they're not myeloid, or they're not plasmacytoid dendritic cells, but they're mainly myeloid dendritic cells that have antigen presenting function, not a function to give secrete interferons. There's not many B cells, but there are many plasma cells in IBM muscle. And we showed that there was an antibody present in 50% of our patients. Subsequently, we identified this antibody to be target cytosolic 5' nucleotidase. At the same time, a group in Holland also demonstrated this. And it's a pretty specific antibody. And we find it in 50 to 70% of patients with IBM. It can also be seen in lupus and Sjogren's, but it's pretty specific, and it's very helpful, particularly in a patient that you do a biopsy and you don't see a rim vacuole, or those patients that don't have the classic pattern of weakness. If you see the antibody, it's pretty darn helpful in making the diagnosis. We had this paper a few years back with Steve showing that IBM is also associated with T large cell granular lymphocytic leukemia. And I would say really it's granular lymphocytic lymphocytosis, not leukemia per se. If you look at the inflammatory cells, there's these granulars, large granules. And there's a lymphocytosis with a high CD8 count, which you see with IBM. These cells are CD57 positive, CD5 negative. And not only do we see this in the periphery and in peripheral blood, we see this as the cell that's the main cell that's invading. It's highly differentiated, associated with natural killer cell properties. And then more recently, we showed this highly differentiated, even further more differentiated along our cells that express the killer cell lectin-like receptor, or KLRG1. This fiber is important in that it expresses interferon gamma. It's a highly differentiated CD8 cells. It is very refractory to steroids and other immunotherapies that otherwise would cause apoptosis and may explain why patients with IBM don't respond to immunotherapy. But it does give one a target if you can create a monoclonal antibody to this cell, and I can tell you that such an antibody has been derived and studies are underway, and hopefully there'll be a clinical trial of this drug in the near future in IBM patients. I just want to mention really quickly about the filaments in the myonuclei. If you look at rim vacuoles, they express emerin. And so it's thought that many of these nuclei, or the rim vacuoles that we see, are probably from degenerated myonuclei that had exploded. So again, in wrapping this up, the T cell repertoire of IBM is oligoclonal. We see an oligoclonal expansion also with B cells and plasma cells. We see an antibody. We see this specific type of T cells. And I think people have wondered, is this a distinct inflammatory myopathy that, or is it a degenerated myopathy with secondary inflammation? I think the best evidence now is that it is a primary autoimmune inflammatory myopathy, and the degenerative aspects are secondary. We just haven't found the right treatment yet. And again, it could be triggered by a virus in genetically susceptible individuals. So in summary, DM-PM antisynthetase syndrome, necrotizing myopathy, and IBM are clinically, histologically, and pathogenically distinct. Dermato is an immune-mediated disorder, which we think is probably due to a toxic effect of type 1 interference on small blood vessels and muscle fibers. PM is a T cell mediated disorder, again, increasingly vanishing pathogenesis of antisynthetase, necrotizing myopathy, and IBM are working out some of the data, again, with the complement being on sarcolemma of non-necrotic muscle fibers, and necrotizing myopathies make one think, could necrotizing myopathy be complement mediated, much like myasthenia gravis. And Chip mentioned anti-complement drugs that have been studied in IBM. They're also now being studied in autoimmune necrotizing myopathy. And dermatopolyantisynthetase and necrotizing myopathy are responsive, but IBM is refractory, but maybe a targeted immunotherapy might be a benefit. And with that, I did my 45 minutes, got a lot. Thank you.
Thank you. أنا عادي. ألو سامعني؟ Okay. Thank you, Dr. Amato, for this comprehensive lecture. It's amazing, actually, very detailed. Now I have the honor to introduce Dr. Kapler. Dr. Kapler is a consultant neurologist of the neuromuscular disorder, specialist in DBT, executive director of the research center at King Faisal, specialist assistant at the research center in Jeddah, Saudi Arabia. Dr. Kapler is the founder of the President of Training, Saudi Arabian Neuromuscular and Electrical Diagnostic Medical Branch of the Saudi Neurological Society. Dr. Kapler completed his undergraduate Dr. Kapler joined King Faisal Specialist Hospital and Research Center in Riyadh from 1996 to 2005, where he was actively involved in clinical research, postgraduate education, and research. He then moved to Oregon Health Sciences University, where he was the director of the Neuromuscular Disease Center director of the MDA Clinic and co-director of the ALS Center of Oregon, and held the position of the Associate Professor of Neurology. Dr. Kapler then joined King Faisal Specialist Hospital and Research Center in Jeddah. Dr. Kapler has authored numerous academic publications, book chapters, web-based educational activities, and abstracts. He has delivered lectures at local international conferences globally. He has mentored young neurologists and has conducted research throughout his career. I'm honored to introduce you, Dr. Kapler. Please start your talk. Thank you.
Thank you, Professor Sama, and thank you for including me in this conference. I really appreciate that. It is 11:30 p.m. here, so I may be a little bit tired while I'm talking, so I'll apologize in advance. What I'll talk about is CIDP, and I put the spin of refractory neuromuscular disorders on it, since that's the topic of the Neurology Club this evening. So what I'll plan to do, and this is just an outline, is talk about the definition, a little bit about pathophysiology, and then I'll become anecdotal and talk about diagnostic evaluation, especially in our environment here, and get a little historical as well, and then talk a little bit about management, and then about several new syndromes that exist. So CIDP, or chronic inflammatory demyelinating polyneuropathy, probably affects about 5 to 10 people per 100,000, and that's globally. And it's a progressive or a relapsing motor sensory neuropathy. And what many folks frequently forget is there's a lot of proximal involvement here. It's not just a distal sensory motor neuropathy. There's a proximal component, and without that, it would be very hard pressed to call a patient or diagnose a patient with CIDP. Symptoms should evolve over at least 2 months, and it should be progressive. But about 15% will have a Guillain-Barré-like presentation, and this gets very tricky. And the real clue is the sensory component, and we've seen patients that have been diagnosed with Guillain-Barré that have absent sensory nerve action potentials, and then there's a little bit of confusion until a few months pass, and patients will tend to have sensory signs, very prominent sensory signs, and findings by EMG, and also there'll be absence of these other components of Guillain-Barré, and that should clue us all into that this may be an acute presentation of CIDP. The pathophysiology has evolved over the years, but it's much, in my mind, less clear than other autoimmune neuromuscular disorders. There's evidence of both cellular and humoral components. There is invasion by T cells and macrophages of the myelin sheaths, similar to other neuromuscular disorders. There can be complement deposition and immunoglobulin deposition around the nerve, and sera can cause demyelination in animals. The problem is there's not a single major target antigen, and likely CIDP is a syndrome, and there might be multiple pathophysiologies going on, and the IgG4 component, or the IgG4 syndrome, or the perinodal syndromes, are evidence of that, and I'll talk about these at the end. This is something that was shared with me by Isabel Ia, and it just shows the complexity of what I've spoke about in words, and it almost looks like multiple sclerosis for those of you who treat it. Here we have the blood-nerve barrier, and then in the periphery we have T cell T cell stimulation, and then we have cellular adhesion molecules that T cells bind to and then traverse through the blood-nerve barrier. And then once inside, we have activation of either B cells that are present there, or antibodies can come in and act. And then we'll also have complement processes occur, and then macrophages sort of cleaning up the myelin. It looks very, very similar to MS, and it's a surprise we're not using some of the MS drugs in CIDP. I think there are thoughts to do that. So what's the most important test for me, and this is a picture about 15 years ago, it's really nerve conduction studies. And at this point in my career, I don't even order blood tests until I do nerve conduction studies. That's how beneficial they are. And really what I'm looking for is CMAP pathology. The compound motor action potential has a huge amount of information within it. And once you even start seeing this type of pathology here, you sort of get a feel that this is an acquired demyelinating neuropathy. And of course, then we see nice conduction block and temporal dispersion. But even in this tracing here, you start to get a feeling for demyelination. There are criteria for CIDP, and they've been revised multiple times, and there are multiple components of it that all suggest demyelination. And the only problem with it that I have is a reduced motor conduction velocity of greater than 30% below the lower limit of normal in two nerves. This is a single component, and this really gives me pause, because a lot of things can cause that slow motor conduction in two nerves, besides an acquired demyelinating neuropathy. So I don't really look at that one personally, and I tend to focus more on this type of pathology, or conduction block, or F waves, or other things. When I do look at labs, by the time a patient gets to me, most of these things have been done already. The things that are not talked about in literature but are relevant, I think, in our region are Brucella and Bilharzia, and both of these can cause motor slowing, or motor and sensory slowing. And I think we've all seen these patients, and I think we don't look for it enough. Genetic testing in our region is critical when we see something that's idiopathic, and I'll share a little bit more about that later on. But whole exome sequencing is readily available, and the cost has dropped dramatically. We do have problems, though, with duplication and deletion disorders, because those type of genetic tests are not readily available, at least in Saudi Arabia. Medications, are more and more causing slowing or demyelination, and this is a list of medications. But nowadays, when I see any patient who's on any medication, I start investigating it to see whether or not it could be the cause of CID or conduction block. And actually, I've even seen one patient with hepatitis who was on stavudine, and within 6 weeks of developing stavudine, he was paraplegic and he had conduction block everywhere. And when they stopped it, it went away, meaning the conduction block and the weakness. So I think many drugs are underappreciated, but this is a list that we should all be thinking about. I think all these patients that have demyelinating neuropathy need a lumbar puncture, and it's extremely important to do it, and I don't think we do enough lumbar punctures on our patients. So in order to impress us, I put the history of lumbar puncture here, and this is a rendition of a lumbar puncture. The first lumbar puncture was done in 1886 and it was actually therapeutic. And in patients with TB meningitis, to decreased intracranial pressure. And then Quincke in 1891 developed a needle, which that needle I think still may be used in some places. And shortly thereafter, though, lumbar puncture was used for diagnosing meningitis by this Professor Wentworth at Harvard. And the story is very sad. When the public found out that he performed this procedure, he was prosecuted. There was an anti-vivisectionist movement going on, and when they realized that he had done lumbar punctures on children with possible meningitis, he was prosecuted. He was supposed to be the first chairman of pediatrics at Johns Hopkins, and because of his performing this diagnostic procedure, that was taken away from him, and he did continue to practice medicine, but he was tainted after that. So what do we see in CIDP? It's high protein, usually between 50 and 200 milligram per deciliter, but it can be much higher. We've seen patients in the grams. And in some patients, you will have a pleocytosis, but it's usually less than 50 cells. And if it is greater than 50 cells, something else should be going on there. HIV, Lyme disease in inappropriate patients, sarcoid, lymphoma are what's cited, but I would also be suspicious of brucella or perhaps bilharzia, although that's less clearly talked about. Nerve biopsies are talked about. I really no longer do them. I did this. This is a very old picture, and it's very easy to do a nerve biopsy, but I really don't see the use for it, and I haven't done one in about the last, five or 6 years. In demyelination, you'll see demyelination by nerve biopsy. Even if you see inflammation, it's not specific. And in CIDP, you really don't see inflammation. If you see anything, it's going to be macrophages or T cells that are sort of pushing themselves into the extravasating themselves from the capillary into the endomysium and then going in and invading myelin. You also see macrophages in there. So it's so nonspecific that it's really doesn't add value, and you leave the patient with a permanent neurologic deficit in most patients. Of course, there are exceptions. In some cases, you'll revert to that. MRI is something that you can add, and when we're looking at MRIs, we started requesting coronal sections because it's much easier to see nerve enhancement in coronals than in the traditional sagittal or axial sections. And this is cervical nerve roots here. Could be lumbar. It all looks very similar. And in some patients, we do have central involvement in central white matter changes in CIDP. So by this point in the game, we should have probably decided if a patient has typical CIDP, which the components are listed here, or one of the other versions of an acquired immune-mediated demyelinating neuropathy, and we can see the electrophysiological abnormalities, the CSF abnormalities, and all of these are usually elevated. GM1 antibodies, I really don't request those anymore. They're really not as helpful as some of the newer antibodies that are more difficult to obtain. The interesting thing, though, is treatment response, and CIDP sort of responds to everything. Most immunotherapies, you get some sort of response, whereas others you'll have less of a response. For example, in DADS, it doesn't really respond to any of these conventional therapies. MAD-SAM, intermediately to IVIG or prednisone, and multifocal motor neuropathy, the conduction block, really to IVIG solely. So once I've started someone on this, and especially in this environment, with either steroids or IVIG, and you look for a response, and if a patient doesn't respond, then really it's time to rethink this diagnosis. And frequently, all too frequently, it's not an acquired neuropathy. So this is a patient here that I saw some time ago, and he came in with resistant CIDP that had failed all types of therapies, and they were considering cytotoxic therapy like cyclophosphamide, and he wanted another opinion, and he came in here in a wheelchair. So, of course, he told me there's no family history, and I was sitting there looking at his son, and this is his son, and the son thought he was perfectly normal and that his feet were perfectly normal because everybody in the family had feet like that, and of course, this is a family of Charcot-Marie-Tooth. I've had so many occasions of that here where the whole family has been normal that routinely now, before I start someone on an immunomodulating journey, I usually screen family members, both clinically and electrophysiologically, to be sure that I'm not dealing with a hereditary neuropathy. And once I started doing that, my CIDP cases dropped dramatically, and my hereditary neuropathy cases here have increased dramatically. And additionally, this is another reason to really look at spinal fluid. Although you can sometimes in Charcot-Marie-Tooth have mild elevations of CSF proteins, it's less common than more common, and it will help you in these patients where you're not really sure about what's going on. So let's look at the axon and the myelin and the node of Ranvier here, and this is again courtesy of Isabel Ia in Barcelona, and here's our two proteins that we've been talking about, our two antibodies, myelin-associated glycoprotein or anti-MAG syndrome, when we develop antibodies against MAG, which are usually IgM, and here's GM1. The protein, and again, we have antibodies to GM1 in a lot of disorders. I don't know how useful it is. There were some very elegant experiments done looking at sera from CIDP patients that were put on T's nerve sections and to see if you could find staining. And sure enough, in this region there was staining, and it was unclear, which proteins that were being stained, but over time it was understood that this complex here, neurofascin and contactin-1 and Casper, were candidate antigens in autoimmune neuropathies. That said, though, there are a lot of antibodies that have been identified, and it's not clear which of these are really important, except for perhaps those three that I mentioned earlier. Just a word about MAG, since it is a very specific syndrome, and it's usually an IgM monoclonal gammopathy with anti-MAG antibodies that are existing in patients that are usually older. They have sensory loss uniformly and weakness almost uniformly. And tremor in some patients. And interestingly, in these patients, there is demyelination, but no conduction block. Their pathology looks a little more axonal. I think we artificially differentiate axonal and demyelination, and that's why I focus more on CMAP pathology rather than velocities at this phase of my career. So getting back to the paranodal syndromes, and here we have the node of Ranvier, and here we have this protein complex that really binds this paranodal myelin loop to the axon, and it's composed of these 3 protein complexes. And there are other proteins that could be identified, but we'll just focus on these right now for the purposes of the remainder of this talk. The first protein that was identified was contactin-1, and there was a phenotype that was pulled out of patients that were older with an aggressive neuropathy, predominantly motor. There were early axonal damage, although there were demyelinating features, but usually by the time people saw them, they would look like a severe axonal neuropathy. These people responded poorly to IVIG, although they do respond to plasmapheresis, and that was interesting and not intuitive. When the antibody was identified and isolated, interestingly, it was an IgG4 antibody, and IgG4 antibodies are important and interesting because IgG4 syndromes tend to respond to B-cell depleting therapies, and the reason that it appears to be that is there's not a complement component in these syndromes. So this was in 2013. This was identified, and then people started looking into their patients, and in numbers like 2 to 6% of CIDP patients by this one Dutch group had this particular antibody. However, if you would enrich the population to the appropriate phenotype, they thought up to 17% of these patients would have that antibody, whereas Guillain-Barré patients in this particular series were negative. And in 2015, a similar thing was found where it was about 2.4% of these patients in this series had this. And however, more recently, there was a large French group that looked at over 1,000 CIDP patients, and they found 1 to 2% of patients with these antibodies, and so the exact numbers are unclear. So if we look at the neurofascin antibodies, so just to remind ourselves here, is neurofascin is on the opposite side. It actually binds to the myelin, whereas contactin binds to the axon. It was also identified, and then reports started appearing about anti-neurofascin antibodies in peripheral neuropathies. And in this particular group of patients, they'll have both central and peripheral demyelination, similar to those images I showed you earlier. A clinical phenotype appeared with some differences. The ataxia and tremor were more pronounced in this version of CIDP than others. There was no early axonal damage, and it was much more a demyelinating neuropathy, and there was either no or a poor response to IVIG, and a response to plasmapheresis was noted, and again, this was an IgG4 isotype. So the Spanish group, led by the Barcelona group, I should say, started looking at these patients and identified this group of 4 patients that had IgG4 antibodies against neurofascin, and they felt that this was a specific phenotype. And you can see the titers of the antibodies were high, and to my knowledge, these are still very difficult to obtain. Although we've received them through research laboratories, but not through clinical laboratories. They're not available locally or in our reference lab at SynLab in Germany. So when others started looking at it, again, you saw similar numbers with 2 to 4% of these CIDP patients having these particular antibody subtypes. And and that was true in multiple reports. Isabel E., again in her group, decided to treat these patients with rituximab, and because of the IgG4 nature of the disease and the lack of a complement component, to see if these patients would benefit from it. Although it's an open label study and there are small numbers, 3 of the 4 had improvement, and 1 of the 4 had 10 years of disease, and that was severe and stable, and did have some improvement after B-cell depleting therapies. They do say the 4th patient had a stroke unrelated to treatment, but I'm concerned because we know rituximab does have some sort of a cardiac toxicity, and it could be related to rituximab. So the IgG4 disorders are expanding in our world, and I think we need to understand that because they are more amenable to B-cell depleting therapies, and we see this occurring more frequently now. One thing that I will say, though, is with some of these antibodies, you can have either IgG3 or IgG4, and they do have different phenotypes. So I'll conclude in saying that CIDP is really heterogeneous, and now we have some specific autoantibodies that are associated with disease subtypes that we should be aware of that, especially when patients don't respond to standard therapies. I think this is more important than it used to be. And in these new syndromes, the node of Ranvier is the target, and these IgG4 antibodies against either neurofascin or contactin-1 do have both clinical and therapeutic value, and rituximab may be a treatment option for those patients. And I'll end with that, and thank you for your attention. This is Jeddah about a year ago, and unfortunately we haven't been underwater since then, and hopefully by next summer we'll be back underwater. Thank you so much.
Thank you, Dr. Kabler, very much. Very good lectures and details and comprehensive. I think now بولس احنا on air ولا ايه؟
Okay.
السلام عليكم. احنا thank you for the 3 eminent speakers, Dr. Howard, Dr. Amato, and Dr. Kabler, for these very interesting talks, comprehensive in a very difficult diseases we see in our neuromuscular clinics. I have to introduce my colleague, Dr. Hazem Marouf. He's a professor of neurology in my department. He's the director of the postgraduate scientific program and director of the neuromuscular program also. Dr. Hazem, you can start to have some questions from the audience, please.
Okay. Dr. Howard, it's, the first question is actually for me. I'm talking about a female patient, 40 years old, with long history of myasthenia. And for the last 5 years, she is almost okay, except she has a bulbar symptoms. She is now receiving SEP or 2,000 milligram daily, together with a small dose of steroids and metronidazole for 6 times per day. She has no facial weakness. She's doing most of her daily activities, but the only problem is she has a nasal tone of speech and she has mild bulbar manifestation. Do you consider this patient as resistant myasthenia gravis? She actually tried IVIG and tried plasma exchange several times, but still have the same problem, which is just mild bulbar manifestation. Nasal tone is quite evident, bulbar shocking sometimes, but mild facial weakness, upper and lower limb is okay.
Yeah, I mean, clearly this would be uncontrolled myasthenia, if we can use that term, rather than refractory, because she's somewhat better. My understanding is you don't have access to complement inhibitors.
Yeah.
Has she been hospitalized on a repeated basis? I mean, would she warrant consideration for, you've tried everything, essentially. In these patients in the past, I would use cyclophosphamide and give it to them. And there are multiple protocols. You can use low dose daily. You can pulse it at a higher dose. It started in Mexico. There was a group there who began using it in children who were wearing braces and who were bedbound because of the skin maceration from sweat and everything. So they elected to treat with cyclophosphamide, and they did well. But, it's not without risk with bladder carcinoma at about 3% per year. And I've experienced that, unfortunately. Ideally, you'd like to give her, a complement inhibitor, and the one that's available would be eculizumab. I don't know if there's anyone in Egypt participating in the Alexion 306 ravulizumab trial or the UCB raw pharma trial with zilucoplan. If she were close enough to a study site, it would be well worth enrolling her in that. If she's receptor positive, that's one of the critical criteria.
Okay. May I have a question for Dr. Amato, please? You started clinical cases, so I will have a clinical case for Dr. Amato and have your opinion, please. Do you hear me, Dr. Amato?
Hello? I can hear you.
Dr. Amato?
Yes.
Okay. Okay. I have also a male patient in his early 30s, I think 31, 32, something like that. And he had an aggressive dermatomyositis, very hyperacute onset in a couple, 2 to 3 weeks. He's always wheelchair dependent, dysphagia. The skin rash started to be mild on his hands, the one you described. And now in a few months, everywhere in his face, in his body, is suffering much. This young guy, we tried with him corticosteroid, then we moved to IVIG protocol. He went to Paris and he started different immunosuppressive agents, and all failed. And even his response to IVIG started to decrease. He's not responsive as he was in the start of IVIG therapy. They did in Paris PET scan survey for malignancy. I think couple of times while he was there in 1 month. They did it twice, and they did the tumor markers many times. All the survey you can imagine, and his autoantibody specific myositis was positive to one of them. I don't recall now which one. What would you be advice for the next treatment?
So he's had high dose prednisone.
Yeah, he
monthly
used
IVIG.
I used that, then IVIG, and he's still on IVIG every couple of weeks.
He's
not responding. Excuse me, sir?
Is he on steroids now?
He's still on steroids.
What about like a methotrexate?
No, we didn't try methotrexate. I think we'll start him on rituximab. This is the plan now. So you advise us to.
So you did rituximab,
yes.
IVIG.
Yes, it will be combination. Steroids. And if we start rituximab, should we stop the azathioprine, other immunosuppressants, or do it combination? This is the cases, by the way, who triggered me to do this lecture today. these difficult cases we are meeting in this last couple of months. Yeah.
Some people have tried some, like tocilizumab has been used. From the JAK inhibitors can be tried.
So the rituximab is available in Egypt now. Should we go for it?
I don't know what's available there. The paper in Brain and some of the like tocilizumab and some JAK inhibitors, Janus kinase inhibitors that are being tried. I mean, Chip mentioned Cytoxan. I hate that, but you could try that. But I guess if and you try them all together.
Sometimes so you combine them if it's very
combine them all. I mean, usually I don't do this, and I usually I'll start on prednisone, like a like 60 milligrams a day, and I'll add methotrexate. If you haven't tried methotrexate, I would put them on methotrexate. That's probably better than azathioprine or Cellcept.
Okay. Okay.
I certainly would probably at least start on at least 15, and I mean, if it's really bad, just start it off with the parenteral, like 25 subcutaneous. You can go up to 40 milligrams or more. We usually don't use it that high, but you could use it that high. You can start at 25 and every month bump it up by 5 and see how he does with high dose steroids again. And and again, you could look to see if you got any of these Janus kinase inhibitors are available.
How frequent do you meet such difficult cases, Dr. Abbott?
Do I see the tough cases like this?
How frequent? How frequent? Yeah, these tough cases out.
We probably get like one a month that are like this, that really go through everything. So it's not totally unusual. I mean, that's what I see. I mean, most patients get better, but there are tough ones.
Okay. Can we shift now to another question? Hazim, Dr. Hiba Samir has another question for Dr. Kaplan about Aman disease. Do you like to read her questions about Aman disease?
I was about to read the question of Dr. Aisha.
Okay. Could you collect it? That's very fragmented. Could you collect it already?
Yeah, I understand. This is you, Dr. Anthony. This is from Dr. Aisha Shif, I think, Saudi Arabia. She wants your opinion about a male patient, 6 years old, with 2 years of progressive weakness in both lower limbs. Weakness is mainly limited to the quadriceps, grade 2, grade C, and to the hip flexors, grade 4. CK was mildly elevated, it's about 700. Muscle biopsy shows necrotizing biopsies, lymphocytic infiltration in non-necrotic fibers, and then vacuoles. And this is all about the case. This is a male, 6 years, weakness only in the lower limb, limited to the quadriceps and hip flexors. Mild elevated CK, I think the biopsy is suggestive of maybe what's your opinion, Doctor?
How old is the person?
30 years old.
30.
Yeah.
So I'm sorry, the biopsy showed necrotic fibers. There was inflammation, or there wasn't much inflammation.
These are necrotizing biopsies. These are lymphocytic inflammation in non-necrotic fibers and then vacuoles and cytoplasmic bodies.
Right. So I mean, she's
maybe she's.
It sounds like it's probably going to be a muscular dystrophy with rim vacuoles. I mean, IBM at 30 years old, you're not going to get IBM in a 30-year-old. I mean, I think, and there's a number of muscular dystrophies that have rim vacuoles. I think that's what it's going to end up being.
The basis of inflammatory cells in a non-necrotic fiber. but the presence of inflammatory cells in a non-necrotic fiber. This is the question of being an inflammatory process. She's talking about inflammatory cells invading a non-necrotic muscle fibers.
Right. Well, I mean, I'd have to see it myself, the slides, but again,
Yeah,
just very young. Rim vacuoles are not going to be seen in a 30-year-old. You know, that is a dystrophy. And if there's a few inflammatory, and sometimes it's hard. You get necrotic fibers, and there's going to be inflammation in a necrotic fiber, and depending on how it gets cut, you get segmental necrosis with the dystrophy. It can look like the inflammation is there. You can do MHC staining, one, to see if it's, you know, if there's MHC1, but this is going to be a dystrophy. And, you know,
it looks like a dystrophy.
When it is, it's really going to need to do genetic testing. I can't imagine that this is going to be a inclusion body. I mean, I've seen inclusion body myositis in patients that are late 30s. The only time I've seen that is in patients that have HIV infection. And I think, Ed, you may have written about it. Did you write about that with Marinos? The patients with HTLV1 and HIV? Those are the ones that can look like, I think you had one of the first papers on that, if I'm not mistaken. Marinos. And then they can look like IBM in the late 30s, but at 30, and that's had it probably before then, I would imagine this is. Are you still in Saudi Arabia, Ed?
Yes, I am.
That's who. So you need to see Ed, so you can tell me what kind of genetic testing are available. But that's an easy one.
Maybe Dr. Kabla can help.
What do you think, Ed?
I think it's GNE myopathy.
The GNE, but
we have a lot of.
No, I mean that's the thing. That's usually more quadriceps sparing. If it's the quadriceps, That's the one thing I don't like about GNE. Otherwise, I'd agree with you. But it might be one of these. It might be a myofibrillar myopathy if they're really not attuned to how they look, or one of the other. So see, we have a lot of GNE myopathy here. And we see different phenotypes than those that are described. So some of them are quadriceps sparing, but some of them have quadriceps involved. Yeah.
So now with vacuolar myopathies, we're pretty. This would be the high on the list just based on the epidemiology.
So I agree. Quadriceps sparing doesn't mean it's quadriceps not involved, but I was reading through the hearing that it was only the quadriceps, so that's more than quadriceps sparing. That's quadriceps preferential. So that does bother me for GNE, but you know, who knows? But I think that person should see Ed and get the genetic testing.
Okay. We have a lot of questions. I'll move to the next one. We have a question about the Aman disease. One of our junior staff asking about a patient, 20 years old male patient, underwent plasmapheresis, then IVIG, pulse steroids, no improvements, continued for a year on monthly IVIG, and then he did the stem cell transplantation without improvement. Any recommendations, any further treatment strategy?
For Amon, for the disease, it's Amon.
Yes, Amon.
And he's had stem cell transplant, and there's no benefit.
Yes.
But it's a Amon syndrome. If it's a Amon syndrome, it's a monophasic illness.
Yeah.
I mean, it's Guillain-Barré. That's a monophilic. You don't treat them like so. This is not our treatment, by the way. Syndrome, it's something else.
He came to us after doing all that. He came to the clinic after he did all that, and he came to us.
What's his age and what is his age?
22 years, old male patient.
Oh no. I think I would re-diagnose him. I would do everything from the beginning. And I would do whole exome sequencing and see if this is a genetic neuropathy.
Yeah.
That's what I would be.
He's
That's
either
what
got
I would.
hereditary
You meant he
neuropathy or
was
hereditary
misdiagnosed as
neuropathy.
a man to be and might be a genetic disorder to start with.
Yeah.
Okay, great. Hazem, there is many questions for Dr. Howard still.
Well, Dr. Howard, yeah, I think. Muhammad Anwar was asking one of our junior staff, his assistant lecturer. His question was, can we use tocilizumab, another alternative option in resistant myasthenia gravis?
Yes, the Italians have used it. And Renato Matagazza, who's in Milano at Carlo Besta Institute, has had success with it. I personally have had I've not used it at all, but he has and has found it beneficial in selected patients.
Also, Iman want to ask about what to do in a pregnant female with resistant myasthenia.
In a what?
In a pregnant female with resistant myasthenia.
Yeah, that's a tough one because you want to avoid most of the drugs that we use. The only one I think that is safe is prednisone. and prednisone, huh?
IVIG.
Yeah, you could use IVIG or plasma exchange. Either of those would work.
And we have another question that the studies were conducted on seropositive myasthenia gravis, mostly. What if the patient was seronegative and resistant? What the options for treatment? Is it different?
Yeah, no, I don't think so. And I think complement or FcRn inhibitors will work in seronegative. We have data in a recent FcRn trial with efgartigimod that will be presented this weekend at the MGFA meeting that they do respond like AChR positive. You know, I think many of what we consider AChR negative or seronegative are actually very low levels of antibody. And if we do cell-based assays, we'll identify many of them as having AChR antibody. Our own experience is that seronegative patients respond to all the drugs we use for seropositive. So
do you do thymectomy for them?
I have, and some have had improvement. We've used thymectomy less and less over the years, in part because the trial was going on, the TTX trial for thymectomy, and practically everybody stopped doing them. And that was a beneficial trial, so it's now restarted again. But I have a hunch that with our newer therapies in the future, we're not going to need it.
Yes, I mean to clarify, you stopped doing thymectomy to patients, or?
Yeah, during the thymectomy trial, there was a reluctance by clinicians to do thymectomies around the world, and the frequency of thymectomies dropped significantly. And then when the trial was published, they've now started to come back. And so we do them on patients under the age of 60 without...
This is guidelines, yeah. Dr. Minshawi was a fellow in UNEC also, and now he's the head of the department of Mansoura, one of the regions in Egypt. He was there after Dr. Hazem in UNEC, and he's sending greeting for you. And after asking you another question, do you read his question, Hazem, or I?
Yeah, he's asking about how frequent you ask for thymectomy in your patient.
And
typically, if they're under the age of 60, 65, otherwise healthy, we will proceed with thymectomy at this point in time.
I have a lady, it's like 27 years of age. She has mild myasthenia, generalized myasthenia. She's doing fine with 2 tablets of mastinone, only if she has going to do an extra efforts, like sport or something, and she has no thymoma and no hyperplasia in the CT, do you advise her still to do thymectomy?
Well, I guess it would depend on just how asymptomatic she is. Thymectomy has its own risks. I've not been impressed in adults that thymectomy leads to pure remission. Our young children, particularly Caucasian girls, do very well, and our cohort would suggest that they don't require additional treatment, many of them. But the older you get, I don't see thymectomy controlling the disease completely. So one could argue that her quality of life is fine as it is and leave her alone.
Okay, great.
Not take it out.
Dr. Minshaw, we still have another question.
Duration.
Excuse me?
Excuse me?
What do you do in regards to duration of myasthenia?
Yeah.
Is there a cutoff? I know in the study we had 5 years, but do you use that, or do you use? I'm just brought in because I saw a refractory patient yesterday in my clinic who's had myasthenia for 20 years, and she came in and she asked about thymectomy. She's 50, and I'm thinking, 20 years, I just don't think you're going to get better. But
yeah, I wouldn't think she'd get better. Our target is to get them in under 18 months.
Yeah.
But we'll stretch it to 5 years. Beyond that, I think the yield is pretty low.
That's my thinking too. It just.
Oh, there is another question. How frequent, for all the speakers, how frequent or often you see inflammatory myositis without resting activity on EMG?
How often do you see
inflammatory myositis
without fibrillation potentials?
Yes.
I mean, it depends on, again, what extent you're doing an EMG. I mean, if you study enough muscles and you go like paraspinals and stuff like that, which are the most proximal muscles, if you stick the right muscle, you should see it. I think if it's stone cold normal, it's probably not going to be myositis per se. I've seen sometimes you can see fasciitis though, because it's really inflammation in the fascia. And sometimes there can be a little CK elevation because it's kind of inflammatory cells just kind of tickling some of the muscle fibers and getting a little bit of muscle thing. And you might not see much on the EMG, but I mean, I wouldn't be calling myositis and a active myositis, inflammatory myositis, with the EMG shows no irritability. That would, again, you might be, is that more neurasthenia, fibromyalgia?
Yeah.
That's what you kind of think about.
I mean, where you can get fooled is in the very mild cases. And then we'll use imaging studies of the limb to try and identify a hot spot, if you will, and then target that with a needle. And we found that useful. Yeah. But if they've got moderate weakness and you're not seeing it, I would raise a question about the diagnosis.
Okay, great.
Do you want us to do an MRI to identify the active focus and then target it with the EMG needle? This is quite difficult for us to do, actually. I think it's better.
I mean, I sometimes I'll reserve, if I really think something's going on and I'm missing it.
Yeah.
Then I might push it. But you can also do an ultrasound too. So that's
maybe
cheaper.
Ultrasound
and you can do an ultrasound in your office and look for
ultrasound.
You got to get used to it. You got to do enough normal people so you know what to see, so you can recognize what's abnormal.
Yeah,
that's a cheaper alternative than an MRI for sure.
Cheaper and more easier. MRI is a little bit difficult for us.
Okay, no. We still have
well, we don't do it too. It's expensive for us, so it's hard for us to do it too. In Europe, they do it all the time, but in the United States, we don't do it so much.
Okay, I have still two questions for Dr. Kaplar. What if the CID patient, the resistant one, has diabetes mellitus? I have faced one like that 6 months ago. A severe diabetes mellitus, uncontrolled, and the CIDP. How do you deal with it?
Yeah, well, so I think you have to differentiate, which neuropathy is causing the symptoms, and this is a common problem in diabetics. First, the whole discussion of diabetic having CIDP was a long discussion, but they in fact do have CIDP, and you can treat them and they respond similar to non-diabetics. But in poorly controlled diabetics, what will happen is you'll start developing a diabetic neuropathy that will be misinterpreted as CID. And my thought is this is where the spinal fluid becomes a biomarker. And if a person had a CSF study at the beginning and now they've become resistant, you might want to repeat it then. And if you don't have evidence of high CSF protein, then you'd feel more comfortable. This is now just diabetic neuropathy that's occurring in a poorly controlled diabetic.
Okay. And what he's still asking the same junior staff, Dr. Sami, he's still asking when you consider the CIDP is resistant.
Well, that's a good question. Resistant, the problem with CIDP is you get axonal damage, and you're going to have that axonal damage and that weakness that's persistent. And unless the patient responds quickly and is treated quickly within the first, year perhaps, you're going to have a chronic deficit. I think the real question is there still disease activity? And if there's no disease activity, no matter how much immunosuppressants you're going to give that patient, you're not going to have restorative, you're not going to restore the lost function. That's the problem with not having a robust biomarker besides, the clinical response.
Okay. I have one last question for Dr. Howard, if he still have energy for us.
I do.
Okay. Now, with the good result of the REGAIN study, the design was for a refractory myasthenic patients. Now, after this good result, do you start giving eculizumab to early patient non-refractory if they are coming aggressive presentations or you smell that it's a severe case?
That's a great question. My personal belief is that complement therapy should be a first-line therapy. If we know that the membrane attack complex is destroying tissue, why do you want the house to burn down and rebuild it? We should protect it from the start. In the US, the insurance companies will not allow us to use it in early stages of MG. The two current trials that are ongoing, one with ravulizumab and the other with zilucoplan, are looking at non-refractory patients. And the hope is that if they become approved, we'll be able to use it earlier in the course of the illness. Whether it becomes first line, I think will depend upon cost. Eculizumab is just outrageously expensive here in the US, about $750,000 a year.
Whoa.
Which is absurd. I've been told by one of the manufacturers that they're going to try and price their product around what plasma exchange is, which would be much more palatable to use it, much earlier in the disease course. There is a data gap. We know what the cost of medicine and hospitalizations are, but we don't have good figures in the States because we don't have a common database, if you will, of what lost income from not being at work, what are the costs of all the complications that occur because we use steroids and, azathioprine and, et cetera. And if we can get a handle on that, I think we can prove that using a more pricey monoclonal antibody may be much more cost effective in the total than what's going on. Sure. But I predict that you'll see complement inhibitors, FcRn inhibitors moving way early in the treatment of MG.
Thank you very much. Dr. Hazem, do you still have any further questions for the speakers?
No, I think.
Now we can come to the conclusion, and thank you very much, Dr. Howard, Dr. Tony, and Dr. Kabler. Thank you very much. It was very, very nice, informative day. I'm sure that all the audience get benefit from this vast experience of your work. Thank you very much. Appreciate it.
Well, thank you for
Guys,
Looking forward to you again next in a very soon club, inshallah. Thank you. طيب احنا بنشكر شركة ايفا على السبونسرنج الايفنت النهارده، ومعانا الدكتور احمد الجهاوي من شركة ايفا will talk to us about the portfolio of his company. اتفضل دكتور احمد.
Thanks, Dr. Sameh, and thanks, Dr. Hazem, and I would like to thank you for this great night and the great evening for scientific evening and letting us to sponsor such an evening. I will be quick in my presentation and review our portfolio in EVA Pharma for neuroscience portfolio. We are in EVA Pharma. We are trying to cover all the areas that you are facing in neurology or neuroscience part. So I will take you an overview in our products. First therapeutic area is Parkinson's. We have the famous pramixol dihydrochloride, which is with two concentration, 0.25 milligram and 1 milligram. Also regarding the domain and the therapeutic area of Alzheimer, we have two anti-Alzheimer diseases, which is donazil and ravimintine. Donazil is donabizil hydrochloride 5 milligram, and ravimintine is memantine hydrochloride 10 milligram. And regarding the anti-epileptic products, we have currently two products in market, which is Zonivan, zonisamide 50 milligram and 100 milligram, and Oxygrex, oxacarbazamine acetate 300 milligram. And we currently are introducing our newest molecule in the Egyptian market, which is the third generation dicarbamazepine, which is Lepsilive. Lepsilive is eslicarbazamine acetate. Lepsilive is coming from epilepsy and relief, so its name is Lepsilive. We'll be launching it with two concentrations, 600 milligram and 800 milligram. It will be available in the Egyptian market within the next months, and we will surely have more meetings and more detailing about the Lepsilive. Also regarding the psychiatric part of the neuroscience portfolio, we have the famous antidepressant paroxetine CR, which is the only full range paroxetine CR in the Egyptian market, with its concentrations 12.5 and 25 and 37.5 milligrams, which is the only full range available in the Egyptian market right now. Also, we have the part of antipsychotic products, which is olanzapine 5 milligram, to complete our portfolio in neuroscience portfolio. This is a short presentation regarding our EVA Pharma for this opportunity and having us in this great meeting. Also we will have a lot of meetings later on regarding the Lepsilive eslicarbazamine acetate. Thanks, Dr. Sameh, thanks, Dr. Hazem, and thanks for all the attendees.
Thank you, دكتور أحمد. بنشكر شركة إيفا على الدعم والسبورت للإيفنت النهارده، ونشكر كل الاودينس اللي حضروا معانا من الدول المختلفة. Thank you for all the audience from different countries. Now we can conclude the session. Thank you.